All right, let me proceed further on. We spoke quite briefly about uh, commonly used fertility rates. Now let's talk a little bit about mortality rates. Why we're interested in knowing what is the mortality rate, what was the mortality rate in a given country in a given year, because that affects the size of the population. Again, many politicians, policymakers, planners uh, rather prefer to use the crude death rate, which is the number of deaths from all causes per thousand of population in a given year, like the number of all deaths within that year divided by the total population and multiplied by 1,000. Looks quite easy to understand, but there is a big underwater stone in this. And I will explain what I mean. Uh, let's look at this graph. Um, these mortality rates are per 100,000 of population in the year 1980 in a few selected countries like Finland, New Zealand, France, Japan, Egypt, Venezuela, and Mexico. It's not a total number, again, it's a crude mortality rate, so how many people died per 100,000 of population in that area, in that country. Well, normally we have to expect that in poorer countries, because of the lower quality of life, lower economic, the worse economic conditions, more people die, right? But if we look at these, we will see that the least or the worst situation in terms of mortality is in Finland. And the top leader here, according to this graph, is Mexico. So in Finland, 491 people died per 100,000 population in the year 1980, and in the same year in Mexico, only 90 people died. So therefore, when you are an official in, say, the UN or any other international organization, and you're thinking about helping countries which are worse off, you will direct your international humanitarian or whatever other kind of aid to Finland. But the issue is not that simple. We use another kind of mortality rate, which is age-specific mortality rate. What you do, you calculate the mortality rates, like the crude mortality rate, crude death rate, in not for the total population, but in separate age groups, from 0 to 4, from 5 to 9, and so on. So you come up with the death rates in each of this group, and then you sum up these values, and you divide that by the number of entries or the number of age groups. We call it age-specified or age-standardized mortality rate. And that makes a huge difference. Let's look at the same graph. Now, in the second column, we have the standardized death rates for the same countries within the same year. And now you see that the situation is quite different. So therefore, for planning purposes, of course, standardized death rates are, more, corresponding to use. But, sometimes it makes, it is very difficult to explain to policymakers what the standardized death rates are, and they rather prefer the simple equation, one number divided by the other and multiplied by, say, 100,000. Now, the other thing what we look at in demography is life expectancy. In other words, how many years of life people live on average in that country in a particular year. Life expectancy. Life expectancy can be measured at age 0 or any other specific age representing expected survival time once a person has reached that specific age. Okay. Simply speaking, based on available life statistics, we can calculate, the statisticians and demographers can calculate if the baby is born today, say in Brazil, what are his chances, how many years of life he or she will live. on average. Okay, and that's important to know because as you remember from that comparison of two kinds of pyramids, the triangular pyramid and the bottle-shaped pyramid, if the life expectancy increases, then the healthcare expenditures, you know, increase exponentially. That's very important to know. Here on this table, I'm having life expectancy dynamics in the United States from year 1900 to year 1996. And you could see here that average life expectancy in the year 1900 was just 47 years. While in 1996, it almost doubled. It became 76.1. So the gain of life years was about 44%. And that eventually means that we have to take care of more people because compared to the previous years, because the life expectancy increases. And also, people in elderly age range consume more healthcare for understandable reasons. It's also, and you certainly know all, that on average women live longer lives than men. Well, I didn't bring up here another table, but because of the deficit of time. But you may find the life expectancy differences across the racial groups, exactly within the same country, or across the ethnic groups, or across the across the groups of people with different economic backgrounds or educational backgrounds. And that's very important again for the planning purposes. Now, what we are also using and what we also use in planning health sector are very convenient things. We call them sentinel or avoidable events. Sentinel means like the guarding numbers, okay? But in other words, these rates give us an understanding how bad or so good or how good the healthcare system is in that particular country. These are maternal deaths, newborn deaths, deaths under 5, deaths within the 24 hours of admission to the hospital, deaths after surgery, and there are a few more. So why these things are important? Because they are avoidable. Let me explain on the example of newborn deaths. Well, normally pregnancy and childbirth is more well organized event in our lives than any other medical event because we normally plan, okay, pregnancy and delivery. So that and normally it should happen under certain medical attention, whether it's a high-tech hospital or whether it's a community health center or correspondingly trained health professionals. So therefore, if a child dies at the moment of birth, that's an emergency. It shouldn't happen. It was not supposed to happen because of what I said, that this kind of events happen under more concentrated medical attention. And the same can be said about deaths within 24 hours of admission. So hospital is not in a very nice place to be in, right? And no one likes to go to the hospital except doctors and nurses or the people who work there, right? And if you still go to the hospital, that means that you have a problem which cannot otherwise be resolved rather than by doctors in the hospital. But if you still die within the first 24 hours of admission, except like some dramatic emergencies, it's an emergency. It's a problem. Okay. The same can be said about surgery. So when you decide about surgery, I'm talking about a planned surgery. You go for, say, the hip replacement, which is nowadays a very common operation, and you die of sepsis. That means that there is something very, very wrong in the hospital and in that particular country. So therefore, when I, as a public health professional, want to know what is the level of development of a given country, sometimes I don't even look at the at their gross domestic product or the wealth they produce per person per year, or the pattern of distribution of the GDP, but I look at the newborn deaths. If it is over 15, while it reaches 20 or more, or 60, for instance, that means that in that country nothing works. So, therefore, for monitoring at macro level the health system, these sentinel or avoidable events are very, very convenient. Do the health planners and health policy makers use them on routine basis? Not always. Sometimes, political preferences play a more important role than this robust evidence. The another concept which I want to bring to your attention is a concept of burden of disease. In other words, what is the economic, physical, technical burden of all existing diseases in our countries? There have been two parallel processes around this concept. The one took place in the international organizations in that domain, particularly in the World Bank in the beginning of 1990s, when they developed more interest in health sectors of the least developed countries. And they started investing huge amounts of money, tens and hundreds of millions of dollars. And my own country was a good example of that, where the World Bank have invested several hundreds of millions of dollars in rebuilding health sector. And the same applies to many other countries. Like, for instance, Egypt was the single largest recipient of World Bank and USAID interventions and their funds. So therefore, international agents, especially the World Bank, was interested in knowing how effectively the money they provided to given countries is being used. And therefore, and they've been thinking of a bunch of different possibilities. In business, it's quite easy to understand whether your investment is worth or not. Because if you invest, say, $1,000 and you gain $2,000, the difference is $1,000, which is your profit. So that means that's a good signal for you to keep up with that business. But if you invest $1,000 and earn only $50, then you experience losses like $950. So you're going to stop doing that. But in the health sector, it's not that easy. It's quite difficult. So the World Bank came with the certain unit for describing the burden of disease, and that's disability adjusted life years. In other words, I'm not going to go to details, it's quite a complex formula. You calculate how many disability-free life years have been gained by $1 invested in a given public health program. It's especially convenient when you want to compare program A to program B. You don't have enough money for both, so therefore you invest either in program A or program B. And then you calculate the number of DALYs, or disability adjusted life years, gained in program 1 and program 2 per $1 invested. And for instance, if we compare say the vaccination to high-tech robotic surgery, the vaccination generally will produce several times, tens of times or 100 times of more disability adjusted life years than the robotic surgery. So you remember I mentioned the Pearl process in England, in the United Kingdom. They've been having the same kind of way of thinking, but they came up with the quality adjusted life years, which involves not only the disability-free status, but the better quality of life. It's called QALY, and I'm proud to tell you that one of the strongest proponents of QALYs in the world was Professor Alan Williams, who worked with the University of York when I met him, and he used to be my teacher of health economics. So I'm going to stop here, so we will see each other very soon. Thank you.